Welcome back to Basic Concepts of Nursing. This is Tracy Hansen. We're going to start talking about Chapter 5 of your IGGY book, Pain. Pain is the fifth vital sign. Pain is what the person is, when the person says it is, and how the person says it is. So pain is very subjective in its origin. Pain is actually one of the number one reasons people seek medical attention. So pain is very common and something that we will be practicing throughout much of our nursing career. When you consider pain, you need to consider the nerves and how pain travels. As it travels from the periphery to the central nervous system to the brain, where it's interpreted, and then the messages are sent back so that the person can respond to what kind of pain they are having. So let's go ahead and get started with pain. It is a universal, complex, subjective experience. For the nurse, our primary role in pain control is going to be playing patient advocate. So we need to believe what our patients are saying. We need to act on the pain that they're having and implement interventions to relieve it. And then we also need to remember that it's important to respect the patient's preferences and values. So there will be some patients that may not want pain medication, and it's okay. We're not going to push our beliefs and our thoughts about pain control onto them, but we do want them to know and be aware that we as nurses are here for them to help them gain good pain control and comfort, because once the pain is controlled and our patient is comfortable, the healing process is going to occur much more quickly. It's not going to hamper why our patients aren't moving, and so we really want to make sure that we have good pain control. So as far as definitions go, you can read this slide, read through your textbook, but as you all know, pain is unpleasant. You know, who thinks that pain is good? I can tell you that from experience of having pain, that it's really, something I'd like to take off my bucket list, and I would like to not have pain at all. Pain is generally related to some type of tissue damage, or it's a response triggering the person to think, ooh, you know what, if I don't do something, I'm going to end up having damage to this tissue. So when you think about that, it's the person that puts their hand or fingers on a hot stove, and then boom, that reflex is to hurry up, get your fingers off. Okay, so you're protecting that tissue from potential damage. However, on the flip side of that, if you were the person that just, left your hand sitting on the burner, obviously we're going to have huge amounts of damage and problems with those tissue. Different types of pain that need to be considered are acute and chronic pain. If you look on table 5.2, page 40 of your IGGY book, it has a nice little chart, and it differentiates between the characteristics of acute and chronic pain. Pain is typically categorized in two ways. So it's related to the characteristics of the pain, or by the psychologic source of the pain. So that is how we come up with acute and chronic pain. Cancer pain is associated with cancer. So that's how that is related as far as your slide goes. And then chronic non-cancer pain is associated with tissue injury that maybe has healed, but they continue to have pain in that site. Or it is common to see chronic non-cancer pain, somebody that has back surgery and they continue to have pain after the fact. So we do need to be aware between acute and chronic pain. Almost everyone experiences acute pain at some point in their life. When you think acute pain, you need to be thinking sympathetic nervous system, because that's exactly what's happening during acute pain. We are initiating that fight or flight response. So do we want to continue to feel the pain? Can we do something about it? What can I do about it? How can I fix it? So with the sympathetic nervous system being responsive, we will see an increase in heart rate, blood pressure, respirations. You'll probably see your patient, kind of warm and diaphoretic. They'll probably be, writhing, turning here, turning there, up in the bed, down in the bed, doing really whatever they can to get comfortable with that. So whatever that sensation of pain is, that will kind of clue you in on maybe how severe the pain is. With acute pain, it is typically well localized. So if somebody's having, let's say, an earache, they know that it's my right ear that I have an ear infection in, and my right ear hurts. That's because of that acute factor of it. It's localized to the ear. Somebody that has kidney stones, your kidneys sit kind of in your mid back, and so they present with flank pain. So acute pain is very well localized. Acute pain accompanies surgery. Sometimes it precedes surgery. But a really good thing to consider when you're talking or thinking about pain management is the use of preemptive analgesia. And that's kind of like when I talked about epidurals and intrathecals, spinal anesthetics. I told you that they sometimes have lasting effects of about 24 hours. So your patient might be coming in to have a bowel resection. Well, we know that maybe this patient isn't going to move very good. They're going to have poor pain control. They're just probably not going to do the best with patient-controlled analgesia or PCA and opioid by mouth. So what they can do is they can give them a epidural, and that can be reboosted, and so they use this preemptive analgesia to decrease pain during the post-operative period. So it's a really good method to pain control. However, the downside of that is, again, your patient is going to run the risk of infection from the injection site, things like that. You might also, if the patient's having abdominal surgery, you might see surgeons infiltrating that incision with some lidocaine just to provide longer lasting effects. Chronic pain is going to be that persistent pain. It occurs for indefinite periods of time. When I think acute pain, I think, less than 3 months. Chronic pain is going to be greater than 3 months. Chronic pain is not well localized. The character and the quality of the pain changes as time changes. It's very difficult to describe. It's hard to pinpoint. And the patient may have chronic pain that can't be treated. And so acute pain responds very well to opioid therapy, where chronic pain isn't going to respond well to opioid therapy. So we need to be aware of adjunct therapies, such as maybe the tricyclic antidepressants, gabapentin, to interrupt those nerve impulses, those types of things. We discussed a little bit about cancer pain and non-cancer pain. And so I would just make sure that you have a fairly good understanding about those different types. With acute pain, the major distinction is that it has the effect on the biologic responses. So as I said, acute pain mimics the sympathetic nervous system, where chronic pain, we won't see those raises in blood pressure, heart rate, respiratory rate, because with chronic pain the patient tends to deal with it and learns to deal with it over time. So there isn't that activation of the sympathetic nervous system like there is with acute pain, because acute pain activates the sympathetic nervous system and warns that patient it's time to fight or flight. We need to either do something or we're going to get hurt. We talked about the responses to acute pain, so these will be manifestations that your patient may present with, and you can also add into that the writhing, the up and down in bed, those kinds of things. Chronic pain, typically it has a gradual onset and is poorly localized, as I said, oftentimes is accompanied by depression, because the patient will tend to stay at home. They won't want to go out. They won't want to do things. And so they become almost shut in and very isolated from everyone else. So it is a consideration to start the patient on an antidepressant if necessary. So sources of pain, the nociceptive pain is either visceral or somatic. If you take a look at table 5.3, you will find additional information about psychologic sources of pain. So the nociceptive pain is typically somatic or visceral, and somatic is going to be up and closer to the superficial area, the skin, the subcu areas, and somatic typically has a sharp burning characteristics. With the somatic, or with the visceral, visceral sits atop our organs. We know that our organs are covered with a viscera, and so visceral pain is the pain that is on the outside of organs, so it is very poorly localized. If you think about a kidney infection or a kidney stone that has now backed up and the patient is able to get rid of their urine, as that kidney swells, that's going to cause that deep visceral pain. So it could be kind of cramping, maybe splitting. But it's due to the viscera around the organs just being stretched. You can also see this visceral pain with chest tubes being inserted. Maybe the patient has a JP drain that's sitting in a wrong spot and is causing irritation to the viscera as well. Neuropathic pain is on the contrary. Neuropathic pain typically develops from nerve fibers. So it could be related to the spinal cord and the central nervous system. Neuropathic pain is the type of pain that diabetic people have when they have pain, such as like they will complain of burning, fiery, shooting, that typically runs along that nerve. And so that's a difference between neuropathic pain and nociceptive pain. Phantom limb pain also goes along with the neuropathic pain. And the phantom limb pain is a very strange phenomenon. And I've seen patients with it. They feel that that limb is still there and they continue to have pain even though they've had an amputation. So it is really kind of very interesting to take care of them. We next need to consider the theoretical basis for pain. So we need to consider how pain is transmitted. So typically the pain is going to originate in the extremities. So there again, it's the finger on the hot stove. We're causing that transmission via the peripheral nerve, spinal cord to the brain, back, spinal cord to the periphery, and then us reacting. If pain is not transmitted to the brain, then if that pain is not transmitted to the brain, then something has had to go wrong with the nervous system. So that would be inconsistent, or that would be consistent with your patient with a spinal cord injury, could be consistent with a patient severing a nerve, those types of things. So when you were thinking about pain, remember the specific fibers that help transmit the peripheral pain. And hopefully you remember these from anatomy and physiology, the A delta fibers, and those are found primarily in the skin and muscle, and the C fibers, which are distributed in the muscle, the periosteum, and the viscera. Both of these nerve fibers are capable of accepting nociceptive stimuli. The A fiber, delta fibers, are myelinated, and remember with myelinization, that makes things move more rapidly. It's like the slippery snake. The person feeling stimulation to the delta fibers can generally localize them, and they are fairly well defined. With the C fibers, they're unmyelinated, so they tend to travel more slowly and require thermal, chemical, or strong mechanical impulses to stimulate them. C fibers are more diffuse. They cause a more diffuse type pain, typically a dull, burning kind of pain. It's very much different than the sharp pins, prickly aspects of the A delta fibers. So I'm going to stop here, and then we will move on to the different theories of pain transmission.